All right, welcome everybody. I'm going to be starting with Tina and with a couple of questions and then go around to the other panelists. I will introduce everybody first. We are recording. On your screen right now is Sergeant Antonia Gonzalez, and she has an Associate's in Science and Psychology from Thomas Edison State University, a BA in Health and Wellness from Ashford University. She's an MS candidate in the Science of Criminal Justice from Ashford University. And she's a sergeant in the Patrol Division in the Long Branch Police Department. She has been a police officer for 24 years. On her own time, she developed a resiliency room, which we're going to hear about shortly. She developed her own website on wellness and also has a blog. Let me pull up, up on top, we have Stephanie Samuels. She is a psychotherapist who works exclusively with police officers in New Jersey and Oklahoma. She has lectured all over the country on PTSD and vicarious trauma. Ms. Samuels began her career as one of the teens in the first focus group of Teen Line Cares, a mental health helpline for teens. Ms. Samuels recognized that teens only trusted and confided in other teens. With this concept in mind, she went on to create 2 new law enforcement officer hotlines. She is the founder and current president of CopLine Incorporated, the first confidential national law enforcement officers hotline in the country, manned by retired officers. She is the general partner of the Counseling and Critical Incident Debriefing Center, which specializes in debriefing and long-term counseling of first responders and their families. We have Bradley Cooper, a licensed social worker and the suicide prevention coordinator for the U.S. Department of Veterans Affairs, New Jersey. And last but not least, Tina Booth. Let's see where she is. Okay, this is Bradley Jacobs. And Tina Booth has worked in law enforcement. She has been working in the mental health field for 16 years. She has a BA from Georgian Court University and is certified by the state of New Jersey as a psychiatric screener. She currently works at Monmouth Medical Center in Long Branch as a community outreach specialist and psychiatric screener. She plans to enroll in nursing school. I'm going to start with Ms. Booth and then go around and ask questions of each panelist and keep going around till I've finished. You're going to get a lot of valuable information today, and I'm glad that you all were able to join us. Oh, we've got a couple more people waiting. Let me admit them. Okay, hold on. Okay, come on. There's 1, 2. I don't recognize the other one, but I assume it's, let's see who this is. We'll hope we don't. Okay. Welcome everybody. We are recording, and I'm going to begin with questions of Tina Booth. If everybody else would stay muted, and when I call your name, if you would unmute. Ms. Booth, what are some signs that someone is getting depressed or that their diagnosis of depression needs attention?
Yeah, hi Janet. So generally some signs that somebody is getting depressed would be, of course, a sad mood, which is, more persistent than someone on a regular basis. Maybe some isolation, where you notice somebody isn't socializing regularly, like with family and friends, as they usually would. Maybe a lack of self-care, where they're a little less grooming, their presentation doesn't look the same as it would. Or if it's a friend that you talk to regularly, maybe just a lack of motivation or some general like helplessness. So they just don't have that sense of being able to accomplish much, and everything kind of is a little hopeless. Those are some basic signs of depression. Also, maybe some lack of sleep or disrupted sleep are some signs of depression. For somebody who's already diagnosed, sometimes it's a little easier. Family might be aware of some appointments that they're supposed to be keeping up with that they're missing for therapy or with a psychiatrist, non-compliant with their medication. So sometimes that's a little easier to pick up on.
Thank you. What are some more serious signs that might indicate someone is considering suicide? What should the person at risk do if these signs are present? How should someone handle the situation if he or she notices these signs in a friend or acquaintance?
Yeah, so of course, some more serious signs is when things are moving more into a crisis. And maybe someone notices that the person is having some really significant mood changes. So there's like some bouts of anger or some substance abuse that starts that isn't typical for that person. In children, sometimes you might notice some running away behavior or a sudden like change in their friends group that isn't typical for them, a different type of friend group. In elderly population, sometimes there's a lot of withdrawal, maybe some financial planning, addressing some insurance policies or changing some money and moving some money around might be a serious sign that somebody's planning to end their life. Also addressing sometimes some relationship issues with people to kind of make amends and stabilize some things with people that they've had some problems with. That's sometimes something that people will do to try to settle things before they might be planning on making an attempt. So those are some more serious signs. And of course, we always consider too at the crisis unit risk factors, prior suicide attempts, somebody who is involved in substance abuse. Those are risk factors that really escalate the situation, and we try to take it a little bit more seriously. Somebody who has means to attempt suicide available to them, readily available, is sometimes a little bit more likely to attempt. Somebody who's had like some kind of significant recent loss, and that doesn't have to be a death. It could be a loss of a job or significant financial loss. Those are risk factors to take into consideration. And then as far as what to do about it, I mean, the person themselves, if the client is experiencing these symptoms themselves, often they're not going to be acting on addressing it and having like help-seeking behavior themselves. We would hope that the person is, but if they are, then they might be contacting their therapist or going to their, would be a go-to person, their friend or a family member or whomever it is that they speak to comfortably. Maybe they're contacting their psychiatrist or, a teacher, whomever. A lot of kids now have a resource called the Second Floor, which is a kids hotline that they can text, which, they're more comfortable with a lot of times. Instead of calling or getting on the phone, they text any time of day, and it's a hotline for them. But, if there isn't that help-seeking behavior, then, somebody else is noticing these signs and wanting to do something to help, then really you would have a conversation with them. And people skip this step too often. Having this honest conversation with somebody is really important. Asking them directly, are you having suicidal thoughts? And people are afraid, I think, to discuss this and have a conversation about this, but it's very important. The more we talk about it, I think, the more it's going to become okay, to address it and to have conversations and really to get more involved in prevention of suicide rather than waiting until it's too late. But really to ask directly, you know, are you having suicidal thoughts? And then if those thoughts are confirmed, you could always bring the person to any nearest emergency room. And if they're not willing to go, you could call a crisis unit for guidance on how to handle it from there.
Thank you. One more question before I go on to the next person. What are some additional risk factors of depression that medical staff are exposed to due to their work?
Yeah, well, medical staff, a lot of, you know, emergency responders are exposed to some trauma. And, you know, when you look at situations where, you know, either you might be seeing dead bodies or, you know, you're dealing with situations where families are going through trauma and you have some people who are having a hard time empathizing and really, you know, drawing the line and being able to shut that off before they go home at night. For a long time, sometimes medical professionals can experience some burnout. You know, the stress of the job and having to be that person to provide the help and support all the time, and you know, be able to function in those crises and in those emergency situations and not really let the environment and the stress get the best of you can become difficult when you're doing it over and over and over again for an extended period of time. So after a certain period of time, sometimes people will get burnt out and, you know, just lose their motivation to be doing the job that they're doing, and really not recognize that this is happening to them. So it's good, you know, when you have coworkers or administrative staff that can, you know, pull you in for a supportive talk and let you know that maybe you need a little more self-care. But the, you know, the extra hours, you know, being available any time of day, you know, when things get, you know, a little wild out in the world, like recently, especially with COVID, we've all noticed, you know, the need raises for medical personnel and all emergency staff, really. You know, the need for our work doesn't diminish, it just gets greater. And so while we still have our personal lives and our families and things like that to handle, we also have work that we feel obligated and
Thank you. Sorry, I had a computer issue for a second. Sergeant, Mr. Jacobs, are veterans more at risk for suicide than other people? And if so, why?
Hi, Janet. Thank you for having me. I do want to say that I do wish, I don't wish I was Bradley Cooper, but I do wish I had his money.
Oh, did I say Cooper? My bad.
So your question is an important one. Veterans are 1.5 times more likely to die by suicide than the general population. Over the last couple of years, the rate of suicide among veterans compared to the general population has slowed a bit. No one is 100% sure why, but the VA has been engaged in a pretty large public health initiative to prevent suicide among veterans and partnering with other suicide prevention efforts in the larger community. You know, within the veteran population, older veterans still die by suicide the most, but veterans between 18 and 35 are have the highest rate of suicide. And then we are starting to see an increase in the rate of suicide among female veterans. And that there's not a lot of clear indications as to why, but you know, some of the assumptions are that there's more exposure and more combat among female veterans, and they're increasing in numbers in service in the military.
Thank you. Sergeant Gonzalez, based on your experience and reading, how prevalent is suicide among police officers and other first responders?
Hi, everybody. Thank you for having me, Janet. I really appreciate being here today. I'm actually honored to be on a panel like this to talk about something that's very serious and that it's kind of frowned upon, or it's taboo to talk about it. But what I'm hearing more and more in the newspaper, and I don't watch television, is that more and more officers are committing suicide. And according to Blue Help, a study that they conducted showed that there was 228 officers that died by suicide. And in 2016, there was a study done, and there was a large number of officers that were committing suicide. Texas ranked third with 19 suicides in 2019. Now, I can go on and on and on with statistics about suicide and everything, but one thing that I must say, it is prevalent, but I think that it could be underreported.
The figure you quoted, was that nationwide?
It was, yes, Blue Help. A study showed that 224 officers died nationwide. And then there's another study that I researched, and I can provide you with that later, but they're still working on those statistics. And let me get it for you right now. So at least 220 police officers died by suicide in 2019, according to Blue Help. That is a large number. 2020, we've already seen quite a few officers reported that committed suicide. And like I said, I've read a couple different, from different states, and even in New Jersey, there was a couple within the end of the year. So the number is rising, in my opinion, and of course, with these facts.
Just a follow up to that, what would cause suicide to be underreported?
Well, there's this, I will tell you from my own opinion is a lot of people would, let's say the truth, they're embarrassed by that. Suicide is something that most people are embarrassed about. And I am not a therapist, but I have had family members that have committed suicide, and no one wants to talk about that, right? So it's that thing that people feel like it's, oh, we can't say anything, but you could save millions of lives by just talking about it and by coming forward and saying, look, this is what's going on. This is what's happening in people's lives. This is what's going on in people's professions. Let's talk about it. I'm even uncomfortable. I don't know if you noticed, I got a little hesitant in admitting that I had people in my family commit suicide. It's not something that people talk about. And I think that in this right here is a great way to address it and to find solutions, right?
Yes, yes. Thank you.
You're welcome.
Ms. Samuels, are police officers and first responders, in your, give your take on this, are police officers and first responders more at risk for suicide than members of the general public, and if so, why? Similar question, but I want your take on it.
So rather than giving you just a take on it, I'm going to give you
quotes.
Yeah, I'm going to try for some facts. Every now and again, I like to mess up people and give some facts rather than opinions. So, so one of the things that we look at that's kind of interesting is that if we match up age, race, or what have you, typically they don't seem to be any higher risk, which is not what people typically look at. However, once you get into the rough estimate of police officers, they're about 24% more likely to die by suicide, using the rate of 19.1 per 100,000 and a general population rate of 14.4 per 100,000. That is approximate what it is. What you do find, though, is that fewer first responders, I'm going to do law enforcement in particular, attempt suicide. And the reason why is because, as the other panelists had noted, that they have the most lethal means available to them. So what we know is that males typically die by suicide. I believe it's three times as often as females, but men typically use guns, knives, and ropes, whereas females normally use pills and poisons. So when an officer makes an attempt, it is normally with the most lethal means and the one that they are quite honestly most comfortable with. It is what can save their life. It is what can take their life.
Thank you. Are there any signs that an officer might be suicidal that differ from the general warning signs discussed by some of the other panelists?
So no, as a matter of fact, I think, you know, as I was listening to them talking about the suicide, the warning signs, and one of the things that is different is the incredible gallows humor that officers have to deal with what is really their everyday stressors. And, you know, and certainly the military will see this as well. So a lot of times it is covered up, their pain is covered up by the gallows humor. Some of the stuff to actually look for is when the gallows humor stops, when everything becomes quite serious, although that's not necessarily an indicator. What really needs to be able to change is, you know, being comfortable saying, are you thinking of killing yourself? You know, being able to ask the question that you want the answer to. You know, many people will, you know, kind of dance around it like, you're not thinking of doing anything stupid, are you? Well, you've just done two things. You set it up so I certainly am not going to tell you if I'm thinking of doing anything, because you've made it clear that you don't want to hear it by the way you phrase the question. And the other thing is, to them, it's not stupid. To them, it's the solution. So, so being able to kind of train law enforcement to take care of each other is really training to be able to ask the question you want the answer to. You know, as I always say, you know, I'm not all that cold and callous, but I really don't care if you're going to hurt yourself. The bottom line is, are you going to kill yourself? That's the question I want answered. So being able to be honest and upfront, and, you know, people have said, well, you know, it's the old kind of thoughts. Well, if I say something to them, then, you know, then I'm planting this seed. So I always say, when you were growing up and your parents said, don't have sex, did they plant a seed that you didn't know that you wanted to have sex? You know, same theory. You didn't jump off and have sex because they talked about it. So we need to kind of retrain, and people like Tony that are really doing so much work in the resiliency field and being able to make what they see on the streets abnormal and talking about it normal. I mean, that's some of the shifts that we need. But no, I mean, the signs, the symptoms, but one of the other pieces is that differential diagnosis, which is a lot of the signs of depression also line up with post-traumatic stress disorder, post-traumatic stress injury, I mean, whatever we're calling it these days, you know, it's all lined up. So being able to talk to a culturally competent therapist, particularly with first responders or anybody that's working with military or first responders, really has an obligation to understand kind of, because as you go down this slippery slope and you can clearly diagnose with depression, but the etiology to depression and post-traumatic stress disorder are different. And that's where the importance is, I believe, in helping potentially save a life.
Can you expand on the difference between?
Sure. So the initial criteria, and I believe, and I'm sorry, the gentleman from the VA also is, I'm sure, better known as Bradley Cooper, but that that he can also certainly piggyback, which I think is important. But the key is that the person was exposed to an event or events that involved actual injury or death or serious threat to the integrity of self or others. So that kind of is the key. And then you have the other kind of pieces. you know, the difficulty with sleep. I mean, ask officers about their sleep patterns, ask military about their sleep patterns. They're horrendous. So, you know, difficulty concentrating, you know, check, like we go through this, but these are also post-traumatic stress issues. So being able to kind of figure that out and being able to talk about it, you know, we are tasked to do important work below the surface. Kind of like there's this beautiful post-traumatic stress iceberg. If you haven't seen it, go look it up, where you've got the tip of the iceberg that's out, but all of the emotions and everything else that this beast looks like is under there. Well, as a therapist, you're being tasked to make sure that you ask those questions, that it is your job to dig. It's not the person that's sitting in your office. You're just stealing money at that point. You've got to be able to ask those questions to be able to really deal with it. You've got to be able to ask if you thought about killing yourself. What are they afraid of in the answer? I'll tell you right now, they're afraid they're going to take their gun. If I take their gun, I take their livelihood. If I take their livelihood, I take their wife, their children, I take everything. And the truth is that if you look at law enforcement, that they go south really fast, they go north really fast too. After a suicidal crisis, that person might never be suicidal again. Number one predictor is somebody who's made a prior attempt. You know, when she's talking about, you know, substance abuse, it's like, yep, check. Talk about relationship issues, you talk about all the other components. And the research that was done years ago through NYPD by a woman by the name of Dr. Ivanoff showed that relationship issues was the number one reason that officers took their lives. Interestingly enough, she put job stress as almost at the bottom. So I started thinking about that, and I have a pretty sizable practice. And certainly I'll agree that relationship issues are up at the top, but I also will say that should they not have had the career, I am not so sure that they would have the relationship issues that they have. They're not used to discussing things. The more time an officer spends on the side of a road chit-chatting with the person that they're going to be arresting, the greater the chances that something's going to go wrong. So they're not, you know, they're not experts on communication. There's also a profile I'm seeing now. You know, policing has changed. We've got young men and women that are coming onto the job with absolutely no background in anything that would give them that resiliency that Tony talks about, because resiliency is really built by having to go through traumatic events and surviving them, but they have nothing to hold on to, as compared to the other profile of a cop, which is somebody who has grown up in crisis, does well in crisis, doesn't know how to live without crisis, somebody who has issues with a father figure or significant loss early in life, somebody who has history of abuse, emotional, physical, sexual, or neglect. Now, that makes for one resilient cop, makes for a very difficult relationship. But again, very, very important to understand, because one, you have resiliency, the other, you're going to hope for what they're now looking at is post-traumatic growth. So probably an incredibly lengthy way of answering a question that I hope I answered.
Thank you very much. I'm going to go back to Mr. Jacobs. Is anything working to help reduce suicide among veterans?
Sure. Actually do want to piggyback on the conversation my
Please feel free.
colleagues just had about, you know, what I failed to mention is the relationship of veterans to guns and the relationship of guns to suicide. And so among veterans, 70% of all suicides among veterans occur due to a firearm. And so when we talk about strategies that work, we do have to wade into this territory of the relationship of guns to suicide. So there are multiple strategies to look at. The efforts around developing evidence-based practices that address depression and trauma and PTSD, and using those evidence-based strategies specifically to target suicidal thoughts. So we do have the capacity to bring people into treatment and look at underlying mental health issues. you know, the other piece when we talk about sort of risk factors or signs to look at, in my experience at the VA, many of the veterans that we work with who are suicidal are also experiencing chronic pain, and medical conditions are extremely important to consider. But when we look at sort of what's been the most effective strategy of reducing suicide, it is in reducing access to lethal means. And so when someone is suicidal and they you know, have that impulse to act on those suicidal thoughts, what we want to be able to do is increase the time between that impulse and the ability to act. And so there are different ways to do that. And, you know, one of the things that we do at the VA is to, you know, when we talk about guns, is how do you have guns and have them in the home and keep yourself safe and your family safe. And so we look to distribute, you know, gun locks. We work with veterans who may be at risk of suicide who do have a gun. You know, we have the conversation, do you have a gun in the home? If they're, you know, sometimes they don't want to tell us because they're afraid we're going to come in and do something to remove the weapons, but our intent is not to do that, but is to say, if you do have a gun, let's think about how you keep yourself safe during this time when you might be having thoughts of suicide or if you're at risk of experiencing a crisis. So we work on strategies, what we call safety planning, that focuses both on, you know, coping strategies for managing stress, managing crises, utilizing the supports that many people have, the natural supports that people have, but also, you know, how do we, what are the typical lethal means you might use? If it's not guns, if it's pills, how do we manage medication in a way that's safe? If it's, you know, and this is just to say that most people have a preferred method. If they've thought about suicide, they've typically thought about a way in which they would do it. So let's talk about what that method is, how we keep you safe from that method so that during that time of crisis, it will take you longer to act on your suicidal impulse. And in that window, we hope that either you will change your mind, the will to live, usually if people have a few more minutes, the will to live will kick back in, or somebody will walk in. And just as an anecdote, when I started at the VA a little over a year ago, one of the first veterans that I came across in my work there as the suicide prevention coordinator was a police officer and a veteran who was sitting in his car, his official vehicle, with a gun, ready to shoot himself. And as he was, you know, getting ready to do it, a friend of his happened to call, and a picture of his kids popped up on his smartphone. And in that moment, his impulse to kill himself left, his will to live kicked back in, and he called and reached out for help. And so fortunately, he got the help, and I'm happy to say that, you know, he is doing well and is alive and well today. But, you know, it's those moments where we want to create that opportunity for people to get access, whether it's to a crisis intervention team, whether it's just a family member who knows to call the, you know, the Veterans Crisis Line or the 1-800, you know, the Lifeline. I say all that to just say, like, we really need to address oftentimes, and the things we're afraid to ask is not just, you know, are you thinking of killing yourself, but how are you thinking of doing it?
Thank you. One more. How do I know if a veteran is in crisis or is suicidal?
Okay. So we, you know, this, just like was being said before, the signs are across the board pretty much the same. I think some of the things that stand out to me when we talk about veterans is a sense of loss of purpose. particularly in service members who are transitioning back to the community and struggling with that transition. There's also among our older veterans, which is also typical among older adults, it could be a loss of someone close to them, isolation from family, could be, just, losing a job and not feeling that connection to purpose anymore, which is something you really want to pay attention to. Veterans who are homeless are at very high risk for suicide. The VA offers, specific resources for homeless veterans as well. So I mean, and the rest of the signs have been talked about. Looking for that sense of hopelessness, feeling like they're a burden on other people.
You and others have already answered the question, is it okay to ask about suicide?
Yeah.
But what do I do if someone I know, a veteran I know, is suicidal?
Yeah, so if you ask and someone tells you, and I think the thing often, one of the reasons besides stigma that people are afraid to ask is they're afraid that the person is going to tell them they are suicidal. So I think the most important thing to do is stick with the person. Don't leave them alone. If they're on the phone, don't hang up on them, and listen. Tell them you're there for them, and that you may not know what to do immediately, but just it's okay to say that, and okay to say I'm here for you. Let's figure this out together. You can call the National Suicide Prevention Lifeline, the 1-800-273-8255, with the veteran and with anybody who is suicidal. If you're someone who doesn't have access to, mental health services. Someone mentioned bringing someone to an emergency room to be evaluated. You can encourage the person to come in and get that assistance. But I strongly encourage people to immediately call the Lifeline, because those are trained responders who are going to be able to help assess what's going on and provide resources to you and the person that you're with.
Thank you. Sergeant Gonzalez, what would you say is necessary for police officers and other first responders to enable them to deal with stress?
Right, so this is super important because obviously there's a lot going on in the media right now with how police officers are being looked at. And it is important for them to find ways to relieve their stress daily, because what happens is that everything piles up on someone, right? So I want to take you through a quick scenario regarding a police officer, right? So a police officer goes to work, they have things happen at home right before they get to work, they have things happen at work while they're at work, they have things happen outside of that police car, maybe in dealing with difficult people. And all that stuff has something to do with the way they react to things and also how they feel. How am I comfortable saying this? I'm going to share with you, I was involved in an incident earlier in my career, and I was very fortunate to have another member in my police department who realized that I was under a lot of stress. This guy was able to tell me, he gave me a lifeline into therapy, right? And it was very taboo back then. I'm on my 24th year, so remember that, right? That was this training that I got from this person, right, was enough to change my life, to help me deal with stress, and to do these things throughout my entire career. It was life-changing. So it is very important for officers to deal with their stress daily, and it is also important for them to have the resources they need, okay, to have that available for them. And that could mean a lot of things. It could be, like Stephanie said, calling in anonymously, having these resources. Everyone here has said the same thing, and I think we're all in it together, obviously, but having services available for them is super, super important, and having that said to them early in their career.
Okay, good. Thank you.
You're welcome.
Let me see. One sec. I have a question here. Yes, Ms. Booth. How has COVID-19 contributed to the stress level of medical and psychiatric personnel?
Well, so obviously just the sheer volume of treatment and you know, patients in the hospital and needing medical attention has been stressful for medical staff. But of course, you know, the anxiety and stress and pressure that it's put on the whole general population has caused psychiatric treatment to really increase. We've had people who are not really already diagnosed with a mental illness that have started to go into crisis, and we haven't really seen that as much as we have been recently, where we're going out and responding to crises for people who have no mental health history whatsoever, and maybe just everything has just become too overwhelming, and it's gotten to a point where it's so much so that they need some crisis response. You know, of course, I think that something that Mrs. Gonzalez touched on is that the general population forgets that we are also human. So in addition to our jobs, we have our own personal lives, our own families that we are worried about exposing them to something like COVID that we may have been exposed to that we're bringing home. We have our children that maybe are having schooling issues or childcare issues that we have to worry about in addition to being at work. So in that respect, you know, the same problems that everyone in the general population has, on top of our stress with work being, you know, compiled and everybody really looking to us as a source for information sometimes, thinking that we have this special, you know, I don't know, channel to the answers to all things having to do with COVID and testing and political answers that we really just don't have. You know, for some reason, sometimes people think that, you know, because we're in the field that, you know, we have the answers and they're coming to us. So there's a lot of extra pressure, a lot of extra stress in a lot of different ways. And it's just really important to keep up with our self-care and being mindful of where we're at and looking out for each other.
Thank you. Mr. Jacobs, has COVID-19 impacted the veteran community, and if so, how?
I would say yes. You know, early on, when things were extremely chaotic in March and April and May, I think many veterans we heard from felt triggered, felt a lot of their, you know, they were very reactive to what was happening and concerned. I think what has had a more profound impact has been the length of time that this has continued on for. And so we've seen an increase in veterans feeling disconnected from whether it's the social networks that helped them feel safe in the community, not having access to do things that were part of their sort of wellness routines, right? Like exercise. And that social connection, though, has been really critical. We have seen an increase in calls to the Veterans Crisis Line. That's actually been a national increase, but there have been increases in New Jersey. One of the things that happens in New Jersey is if a veteran calls the crisis line, they are offered a referral to my team at the VA in New Jersey. Depending on where they live, if they're way South Jersey, they can be referred to the Wilmington VA. And if they're close to Philly, they could be connected to the Philadelphia VA. But our team will try and respond the next day, and we've seen an increase in the number of referrals to our staff in responding to crisis line calls. And so, so the short answer is yes, there's an increase, and I think we're trying to figure out what we're working to really make sure veterans get connected, utilize what resources are available to them in the community, as we are definitely seeing a sense of increased stress and disconnect.
Thank you. One more for Ms. Booth. What resources can Monmouth Medical Center provide when someone is in a crisis? You touched on it, but please elaborate. Thank you.
Just get myself unmuted. Okay. Yeah. So Monmouth Medical, just like many of the other local hospitals, has a crisis unit. So when I had suggested earlier that someone who might be suicidal or admits to suicidal thoughts, you know, you could call or bring them really to a local ER if the person is willing, that's always one good option, because there is a crisis unit where somebody who is trained to do an evaluation there in crisis could, you know, evaluate the risks and what kind of treatment might be appropriate, or refer, you know, discharge them and refer them out to what might be appropriate at that level and that time. However, Monmouth is a little bit unique compared to the other crisis units, where each county has a screening center designated by the state. And so Monmouth is the screening center for Monmouth County. So that enables us to be mobile in the county. So, you know, 24/7, we're available to go out for crisis calls. You know, anybody can call in anytime, providers, families, the police, clients themselves. We have a 24-hour hotline, and sometimes clients will call just for assistance with de-escalation, or we might be giving guidance as to how to handle a crisis. You know, if a family isn't quite sure if this is something that calls for us to come out, you know, we'll help them and guide them kind of through the situation and what to do, how to keep everybody safe. But we respond, we go out always with police, whichever town it might be in, and we kind of do like a, you know, a mini mental evaluation on the spot, determine if there's something going on that's, you know, definitely backed by mental illness, and if it is dangerous enough that it would call for this person to need to be going to the crisis unit, whether they're agreeable or not. So of course, you know, you want a person who is depressed or might be having suicidal thoughts to have their own autonomy to go to an emergency room or wherever it is they might be getting treatment, on their own. However, a lot of times, you know, when somebody's fight or flight kicks in and they're irrational, or maybe their emotions are getting the best of them, or they're not thinking clearly, the family is trying to step in, or friends or coworkers, and trying to keep them safe. And they might have to make a decision where they bring in other people to act on their behalf. And it's usually a last option, but it is very important in crises and situations like this, because, you know, if somebody's having suicidal thoughts, then, you know, we want to make sure that they're safe and they don't do something that they wish they didn't do after the fact.
Thank you. Ms. Samuels, the next three questions are for you. The first one is to get a little bit of your background. Do you come from a law enforcement family? And if not, how did you become interested in working with police officers?
I do not come from a law enforcement background. My father actually was an attorney, okay, and actually at one point worked in DC for the Attorney General and prosecuted drug cases. So he told me that should I ever get arrested, to save my dime and not call him. So definitely not a law enforcement. And I didn't need to use the dime. That was the good news. So I grew up out in California. Like in my background, you heard that I had, I was on a hotline for teenagers. I was in that founding group, which was really cool. In the 80s, Los Angeles was certainly a hotspot for gangs, which had fascinated me. So I thought I wanted to be a cop, ended up riding with LAPD and the Los Angeles Sheriff's Department in their gang detail areas, and realized at some point in time that I did not know if I actually could perform the duties of a police officer. So they came after a pretty ugly call with somebody. So moved back east, ended up working in the housing projects in the Lower East Side of Manhattan, where there are more murders on the Lower East Side on 6th and D than any other location, and realized pretty quickly that mindset of cops and convicts are similar, and had actually realized that out in California working with gangs. And that, you know, at some point in time, you know, cops took a right-hand turn and the gang members took a left-hand turn. So speed ahead, I ended up out in New Jersey and went to the police academy and asked the Director Scott at the time, who was dealing with officers involved in shootings, untimely deaths, child-related incidents, et cetera, and kind of looked at me like your dog does when you talk to him. So when he cocked his head, I was like, oh, maybe I'm speaking LAEs. So it kind of rephrased it, and the answer was really that nobody was doing it. So that became what has now been a 30-year plus quest for me to make sure that officers are taken care of. We do look at statistics, and Blue Health is very big on looking at officers that were involved in critical incidents that end up dying by their own hands. So I wrote legislation. Legislation ended up being passed in New Jersey, which is now known as Cop to Cop. And then I went on to found CopLine. And CopLine is actually now an international hotline for police officers that is answered exclusively by retired police officers. They are vetted, they are trained. It is one incredibly rigorous, difficult training to get through. Our lead instructors with the Los Angeles Police Department in their behavioral science services. Prior to that, he was the director of the Los Angeles Suicide Prevention Hotline, the oldest hotline in the United States. So he's got a dual expertise, and that was truly important to me. I had known Dr. Nagdeman from many years back, and being able to set up something that is truly, truly confidential. So when I was listening to, talking about hotlines and what have you, a couple of things had come up for me. That kind of difference between law enforcement and veterans is all law enforcement officers have to go through a mental health screening and fitness for duty prior to the time they get on the job. And the other is that veterans do not carry a firearm by vocation when they are veterans, whereas law enforcement do. They are, in order to perform the duties, they have to have a firearm. Doesn't mean they have to take it home. And there are ways of being able to secure that as well. So, but one of the big pieces that I think is probably the most important for me to get out there, which goes to my background, which goes every place else. I spent a whole lot of time when I came out to New Jersey riding with police officers, doing ride-alongs. I still do them to this day, all over the United States. So, so having a confidential hotline and what that really means. And, CopLine made a decision that we were not going to take any state or federal funds. And part of that has to do with the requirements that they ask of information. I'm watching you shake your head. That's needed. And the bottom line is the information to us breaches confidentiality. It gives way too much information. I want to be able to look at any officer throughout the United States in their eyes, because the eyes are the soul, and tell them that we are confidential and that they can call the hotline. Because the problem with a law enforcement hotline is if you have a suicidal cop, unlike any other hotline in the world, and your phone is pinged or it's traced, who are you sending to that person's house? An officer. So here's what happens. The officer that responds to the house now tells his buddies and everybody on that shift, and we all know that cops can be like washroom women, it's all spreading, and they're going to say, hey man, don't ever call this line, because as much as they say they're confidential, they're full of shit, because I was just at Bob Smith's house. I took his guns. I took him to the hospital. He's done. Now, you never know if he's done or he's not done, except that's the perception. So the good of the one could never outweigh the good of the many. So having been out in California, having been part of hotlines for really most of my life, what we know is that people that call hotlines don't die by suicide. So the Los Angeles Suicide Prevention Hotline has fielded over 7,500,000 suicidal callers, mind you, suicidal callers, of which 2 have died by suicide on those lines. 2. You're going to breach confidentiality for a line that's been active for 57 years and make it so that cops don't call for that? Nah. So CopLine made the decision to truly be confidential and what they refer to as a non-rescue line. Having said that, because I want to piggyback on a call, it doesn't mean that we don't do everything in our power to save an officer. So we had a suicidal officer, and again, CopLine is not for suicide. It's for all different psychosocial stressors. The belief is that if we can grab them for low-hanging fruit, when there's high-hanging fruit, they will call, and we are absolutely experiencing that. So had an officer who called, our listener, again, well-trained, well-vetted, said, "What is that I hear? It sounds like you are loading a magazine." The officer said, "I am. I'm going to kill myself." So they continued to talk because rapport building is key. And as they talked, she asked him if he would safeguard the firearm just for the call. He said no, continued to talk, built rapport. Officer ended up telling her that he had safeguarded the firearm, continued to talk, continued to deal with the stressors. The listener was able to build the rapport with the caller so that the caller now ended up wanting to get help and made a decision to call somebody in his department that he trusted. Happened to be a small department, called his captain. Third party call. Caller initiated it, kept our listener on the line the entire time. Captain then discussed what they were going to do. Captain was going to make arrangements to have them hospitalized and who the next individual was going to be that they were going to call so that they could take him to the hospital. It was a buddy that was over an hour away. Chief made sure the buddy was around. Caller hung up with the captain, called the buddy. Again, listener stayed on the line for a third-party call. Stayed on that call until the friend was at the house and told our listener that he is now secured and that he's taking him to the hospital. So here you have an incredible way of dealing with a problem that would have been so different if that breach ended up occurring. Happy ending. We had somebody who was a veteran, dual career, who had called the Veterans Hotline. Not such a great experience. It doesn't mean anything. You know, there's plenty of calls that go through the Veterans Hotline. And there was the department was sent to the house to secure firearms or what have you. Individual came out, was very distraught. Situation was he had a fight with his wife. It was non-domestic. And it was the lieutenant that came out that responded that said to this individual, "Listen, call CopLine." And he's like, "I don't want my guns. I don't want," he's like, "I called myself. Call CopLine." And that's how we got the story of kind of what went on. So I think what's really important is that people talk about confidential lines. What people don't understand is where rescue comes in. And their greatest fear, at least amongst law enforcement, and I think this is somewhat where veterans differ, unless they've got the dual career, is that firearm isn't needed to continue to perform the duties and to feed their families, whereas with law enforcement. So So that was really important to me when I went on and I created CopLine, that I would keep it a not-for-profit. I'd be able to make sure that that however we got the funds, that the integrity of these lines would be maintained forever. So that is that. I also want to tell you, and I don't know if you are aware that out in Los Angeles with the homeless veterans population, I saw something unprecedented that was just beautiful the other week, is that the VA has set up tents. They all have American flags on them that are lining, they are both inside the VA property as well as on the streets, to give them safe haven and to help them kind of deal with the stressors. It was absolutely beautiful, because part of it is you've got to meet the person where they are. Bringing them into a shelter doesn't help them if that's not what they want to be. So if they want to be in a tent, how do you set it up for the best outcome? So the VA is just, they had my heart, absolutely had my heart. So just wanted to tell you, in case you haven't been out there looking at the tent city that's been set up, fabulous. So I think that covered that, and I probably answered a couple more of your questions on your list, hopefully.
You covered what led you to found CopLine in your answer to the other question. But how long has CopLine been in existence?
So CopLine has been around. Actually, we've been a 501c3 for 15 years. We went live nationally. The phone used to ring into my office. The Pulse shooting was in 2016. And it was in the middle of June 2016, at which point in time I called up to start having the lines removed from that and put onto a cell phone so they could be answered 24 hours a day. I wasn't quite sure how the hell I was doing that, but I was going to do it. And then came the Dallas 5, which was July 7th of 2016. And I got a call that actually rattled me, and I'm rarely rattled. And a woman said, she's an officer, and she started screaming, "They're killing my brothers and sisters. You've got to do something. Help, please." And I realized that I could help, that I needed those lines to go national, what have you. Sent out an SOS that was answered by actually licensed clinicians that were therapists, obviously, that were law enforcement background, police psychologists. So they helped, and then our first training was done, and we had people manning those lines 24/7 with retired officers starting in April of 2017, and we're going on our 10th training at the end of this month. So we have just about 90 officers. We'll have over 100 by the end of, we're 110, 115 at the end of this training. Unfortunately, not everybody gets vetted to be able to answer those lines. Like I said, it is a really tough training, and they're amazing men and women, but learning how to actively listen and not give advice is difficult for law enforcement officers. Difficult for everybody.
Last question for you. How many emergency calls did CopLine receive in 2019?
So I actually did get those stats before I called. So in 2019, we received 1,541 calls in which was an average of 127 calls a month. Right now in 2020, we've received 1,724 calls. We are averaging 219 calls a month, and we are continuing to see that rise significantly.
Wow. Thank you. Let me see, where am I? Okay, Sergeant Gonzalez, how did you get, would you describe the Resiliency Room? And 3 questions. How did you get the idea? How did you develop it? And who is the Resiliency Room open to?
The idea for the Resiliency Room has been something that's been with me for a while, because what I initially wanted to call it was a wellness room, but that's pretty generic. what happens is for the last 3 or 4 years, I've been talking about stress and how it affects first responders. From my own experience, right? Something always happens and then it pushes you in that direction. And I'm like, well, if I'm feeling like this, how is everybody else feeling, right? So fast forward to a resiliency summit that the state, New Jersey, had sent us to, my department sent us to. I went there and I'm like, you know, I really got to tell somebody about this idea that I have about this resiliency room. And I came back to my department and one of the captains asked, you know, are there any numbers, you know, for officers? Because I'm really worried about them. I don't want them to not have a resource. I said, well, we do have a couple numbers. I said, but we're not done with training. I said, but I really have this idea of starting this resiliency room, this wellness room is what I called it initially. I said, it would be really great if we had a place for officers to go to. I said, not only to relax, but a place if there is a critical incident, right? If there's something that happens, which we've had, right? A place where it could be private when they need to be spoken to. I said, that is really important. So it went on for a couple months and it wasn't as smooth as it looks, you know? And after several months, we found a place that we were using already. And what happened was I went up there and it was full of stuff. So I was like, we got to clean this out. I said, and we have to figure out how to make this a comfortable spot, right? So people can have their lunch and they can do their reports if they want to, or they can just come in and just decompress. So everyone came together, a lot of officers came together and we put furniture together. I had a brand new sofa in my house that I never used. I have a little shopping issue I'm not going to talk about, but I bought it. I took it to the, we took it from my house to the resiliency room. Then we set it up to where it looked like a nice, comfortable spot. There's a salt lamp in there. There's a refrigerator if they want to put their food in there. There's a table if they want to sit and eat. Some people donated some things like the internet and also a television, because there are resources out here where officers can tune into the internet, like mindfulness practices, and that's there for them, so they can listen to a meditation or do a breathing exercise, which I'm getting certified in, and all these things came together. The resiliency room is open to all first responders in Long Branch, of course, right? And of course, if it's not a first responder and they needed that, I'm sure that we would open that to them. You know what I mean? But it is a place that I want to have officers feel safe. You know what I mean? It's not in our police department. It's away from the police department. And I'm not going to disclose the area or the location or, you know, what it looks like, even though they published a couple pictures, just to keep the officers in mind, you know, to be true to them. But thanks for asking.
Janet, I think you're muted.
Sorry, yes, I was. Sorry about that, thank you. The next two questions are for Ms. Booth. What is the community prevention program out of Monmouth Medical Center, and how can they help people who are depressed or having suicidal thoughts?
Yeah, so the community prevention program is exciting in contrast to going out for crises in the community. This is completely different gear. It's aimed towards prevention. So if a call comes into our crisis unit, you know, where it's a situation that isn't really meeting the threshold of dangerousness or for crisis, we can set up an appointment for a preventative appointment or the prevention program. And it's not a response, you know, with police and a screener. It's, you know, you still get a screener, but there's a lot of other professionals that can become involved depending on the situation. So we might involve our substance abuse specialist. We have a peer specialist that can come out. We also have child and family clinicians that go out to see children and do school clearances for them when the school demands that they have to have that to go back to school for making some kind of statement. And also, it's a service that's free of charge to the provider, to the client. So we cover the whole county, and we work more towards, you know, helping people kind of figure out where they're at and what their priorities are and what their greatest needs are at the time. And it kind of works like a short-term case management. So we would go out, do like a mental health assessment on the spot. And again, it is a certified screener. So we are able to assess if there is some dangerousness, you know, if something more imminent needs to be done. But usually that's not the case. The call is usually screened by staff that take the phone call and make the appointment. And so it would be set up appropriately. And a scheduled appointment would be made so that the person is comfortable. We go out to their home or meet at whatever place where they are comfortable meeting. So we can meet at a, you know, a coffee shop or a family's place. So it's, you know, less intimidating for them. And it might be their first introduction into some mental health treatment. So it's, you know, a good way to kind of, you know, help them understand what's available, what services are in the area, and we can link them directly to some services. We can give them resources that are specific for what their needs are. And really just help them kind of weed out what their stressors are, what's going on, and what's the most important thing to address first. And in that, we help really people avoid a lot of crises. So it's really working out. It's getting pretty busy, and it's a nice way to help people who have barriers to treatment. So maybe they have financial barriers, or the stigma of going into an office and making an appointment with a psychiatrist or with a therapist is something that they're trying to avoid. You know, it's not really labeled that way. It's more of a once or twice, we come out to you, you're not going in an office with a big sign. And, you know, we kind of take everything into account. It's not just your mental health, but it's also support and your social situation, financial issues. And we try to use a lot of community and county and state services that are available that people might not be aware of, referring people to senior centers and different resources that are available depending on what their situation is. We offer follow-up appointments for providers, just kind of review coping skills. We can help people develop safety plans. You know, if there's somebody who does have suicidal thoughts from time to time, but maybe it's not something where they have any intent or a specific plan, they're not really in a situation that's dangerous. But it's a longer term or a chronic mental illness, you know, we'll help them kind of formulate how to stay out of crisis, maybe identify where they've gone wrong in the past, you know, and come up with a safety plan and how to kind of better care for themselves and manage that going forward. So it's really all encompassing type of program, available to everyone really who resides in Monmouth County.
Thank you. Are there any resources that are from Monmouth Medical Center that are specific for medical and psychiatric personnel?
Well, not out of Monmouth Medical Center, but there is, just speaking about stigma and kind of how law enforcement may not want other people in the field to know that they tapped into services. You know, medical professionals and psychiatric professionals sometimes deal with that same issue. I'm sure on a lesser level, but the same thing kind of applies. And so there is something called the Emotional Ppe Project. And it is a a non-for-profit organization. It actually includes almost 400 practitioners, and they volunteer their services. They're therapists across the whole United States, and they offer their services for free. But there's an online directory, and it's for medical professionals only. And so what happens is, rather than going through any insurance provider or through any other medical professionals where you're concerned that maybe something might be mentioned, or someone might get some indication that you're getting treatment, this is all confidential. There's no cost, there's no insurance utilized, and it's all kind of to avoid that whole issue of you're being concerned about anyone else in your field being aware that you're getting services. So it's a shame that we're still in that arena, but we are. And so it's a great resource that I came across, all about lifting that barrier. So again, it's called the Emotional Ppe Project, and it's just .org is the website. And they'll give you a huge directory of therapists that are available across the country.
Thank you. The next questions are for Sergeant Gonzalez. Let me see. No, I'm not muted. Ms. Samuel spoke of reasons why first responders might hesitate to talk to a therapist. Sergeant Gonzalez, what can be done to lessen these concerns?
Well, you know that I am a big believer in mental health. I think it's a great thing. I think the reason that most of the times, if I could just say this, many people are told that when you look for a therapist or you speak to a therapist, you're weak or there's something wrong with you, right? And what is important is to have services in the beginning of their training talking about mental health. And this is while they're in the police academy, okay? Talking about mental health and how important it is, and not just 2 weeks of it or 2 sessions. I'm talking about extensive lessons or talks about therapy. To lessen the concerns, of course, everyone here has talked about it, but Stephanie spoke about having confidentiality. That is really key in this, because as I was so open to tell you that I had sought out therapy over an incident that happened, and that was because I was losing my mind, just because it was overwhelming. I couldn't sleep, or all those things that everyone's mentioned here, right? In order to make it better, right? And in order to lessen those concerns and to have these services available, we need to incorporate them in the police academy, not hold it against people if they need it. The confidentiality is super, super important, and have all these things set up in every single agency, and have a contract. Maybe the contract is not the right word, but have a system in place where it's clear what they're not allowed to do, what they're allowed to do, where it's super clear from the beginning. I hope I didn't ramble too much, but I'm really passionate about it, and I really believe in it, and I really love that I'm having these discussions with such wonderful people on this panel.
Thank you. Last question for you. What would you recommend to a first responder who wants to see a resiliency room established in his or her organization or town, or to an administrator who wants to establish a resiliency room in the town? We have one person signed from way down to Tom's River, so.
Awesome. So I would love to talk to those people that want to set up a resiliency room in their departments. And I am currently working on the SOP with my captain, and I'm almost done with it. I would love to talk about how easy it is to do, all right? And maybe something like this, a Zoom call where everybody can tune in and see how easy it is to do. And it's something as simple as this. you have a passionate person that wants to set that up in their department, right? And they want to help other officers. And you sit down and you come up with what you need and what you want for this room. It is never a place, and I want to repeat this, it's never a place for punishment, okay? It is never a place for punishment or in lieu of punishment. It is a place for officers to go that they can do whatever they need to do in there to decompress for whatever time they need. I'm just using my words. Whatever they need that room for is what that room is used for. You know what I mean? And one thing that I'm really super wanting for everyone to know is this is an opportunity for those officers to feel better and to be able to recharge their battery, like my mom says, recharge the battery and go back out there and do what they need to do. And I cannot get away from saying this. We all have a life outside of law enforcement, okay? We have lives, we have families, we have brothers and sisters, we have mothers and fathers, we have problems. We have things that we come to work with sometimes that we pack in a book bag and we don't unload the book bag, right? So it's important to have these services for officers. And thank you for giving me the opportunity to even to tell you about it.
Thank you.
You're welcome.
The last two questions are for Mr. Jacobs. How does suicide impact those who knew the veteran? And how do I learn more about preventing suicide?
So we're starting to pay a lot more attention to the impact of suicide on those who've been exposed to it. So the sort of most recent studies looking at this estimates that for each suicide, about 135 individuals are directly affected. And that includes family, friends, co-workers, other people in the community. And so as we've talked about, imagine the effect of, on other police officers if someone in their unit died by suicide, or healthcare practitioners who had a client, family member, or colleague who died by suicide. And so really trying to understand the toll that could take on someone, and making sure people know that, exposure to suicide can potentially increase someone's own risk for suicide. So the VA and others are sort of refer to this as suicide postvention. I do want to mention an organization called TAPS. They have taps.org, which is an organization that provides support services to family who've had someone in military who died, but they do have a support group for family members of active service personnel or veterans who have died by suicide as well. And so it's important to reach out. The VA also does offer some helpful resources, and I know it's hard to remember this, but we have what's called a Rocky Mountain MyRec out in the Rocky Mountains that sort of takes the lead on suicide postvention, has developed a really helpful resource for families who've had a member of the family who attempted suicide, and how to talk to kids about it, how to talk to teenagers, young children. So it's a really helpful resource that's really for any family member to look at and help you prepare, to have that conversation. I think, like we've said, stigma is a major issue in addressing suicide and mental health in most of our communities. So this is just an extension of that conversation. To learn more about suicide prevention, I think all of the resources that everyone has heard from today are great places to start. I think all these organizations probably have links. If you just Google the Veterans Crisis Line or look up the National Suicide Prevention Lifeline, you'll have a link to resources that can help you learn about, the basic signs of suicide. The VA provides a free resource, one of the many what they call gatekeeper trainings on suicide prevention that we call SAVE, S-A-V-E, which just helps any person in the community be able to recognize the signs of suicide and how to respond to someone in crisis. And that is actually, there's a video online that can be accessed. Janet, I know I sent you the link to it. I'll just mention it briefly here. The SAVE training video can be found online through Psych Armor. That's PSYCHARMOR, psycharmor.org. And there's a link to the SAVE video that comes right up. And that can be a good starting point for really to help anybody who might be in crisis.
Thank you. Thank you to all of our terrific panelists. Since this is a virtual meeting, I cannot pass out handouts, but some of the panelists have sent me resources. If you're a panelist and you haven't sent me a list of resources yet, please email me. I will be putting together a document of resources and emailing it to everybody who attended or signed up for this session. And I thank you all for coming. And stay healthy. And now you know how to help other people stay healthy.
Thank you very much.
Thank you.
Thank you very much for having us.
Have a great week,
Thanks,
everybody.
Janet.
Thank you.
Bye-bye.
Bye, everybody. Have a good weekend.
Be safe.
You too.
Thank you.
Thank you. Thank you for coming.
Very informative.
Good.
Mhm.
Thanks.